In addition to SAMHSA's comprehensive efforts, we wanted to expand on one of your points related to the opioid addiction crisis facing the nation, and we're honored to have Sarah Wattenberg, Senior Public Health Advisor in the Office of Policy Research and Budget in the White House Office of National Drug Control Policy, to share their efforts to close gaps in access to treatment for substance use disorders. Sarah?
Thank you, Catherine and NIHCM, for inviting me to participate on today's webinar on behalf of the Office of National Drug Control Policy. Chris, thank you for your great overview. That helps me a little bit with my presentation. Today's topic is an important one, and I look forward to hearing from today's panelists. Let me first tell you a little bit about the Office of National Drug Control Policy. ONDCP is a component of the Executive Office of the President. By statute, we annually engage in 3 primary efforts to guide U.S. drug policy. We develop the National Drug Control Strategy, develop a consolidated National Drug Control Program budget, and coordinate the implementation of U.S. drug policy by the different federal drug control agencies. You can see that our strategy, our National Drug Control Strategy, has 4 overarching goals to renew U.S. drug policy, to address the public health and public safety challenges of the 21st century. Specifically, our strategy is guided by 3 concepts. 1, addiction is a brain disease that can be prevented and treated and from which people recover. Innovative new criminal justice programs can help stop the revolving door of drug use, crime, incarceration, and rearrest. But today we're here to talk about bridging gaps in access to services, and I'd like to put forth some ideas to close the significant service gaps that are impacting our ability to address the opioid crisis facing our nation. In 2014, over 47,000 people died from a drug overdose in the United States. That's nearly 130 people per day on average. 28,000 of those deaths involved opioids, both licit and illicit, including heroin. Overdoses specifically involving pain medicines have more than tripled between 1999 and 2014. These are staggering numbers, and yet the majority of people with an illicit drug use disorder do not enter treatment. In 2014, 80% did not obtain treatment. We call this the treatment gap, and now I'd like to talk a little bit about how we may be able to begin changing that. Medication-assisted treatment is an evidence-based intervention, but it isn't used as frequently as it should be. Substance use disorders are a brain disease, and we have medications to treat them. Looking at the top section of the slide, there are 3 types of medications that have been approved by the FDA for treating opioid use disorders: methadone, long-acting injectable naltrexone, buprenorphine, and buprenorphine combination products. When these medications are used in combination with counseling and other psychosocial treatments, evidence shows that these approaches are effective. We have a lot of science behind MAT. A recently published systematic review found that treatment with naltrexone or buprenorphine was associated with better retention than a placebo or no medication. And the retention improved further when contingency management was used in addition to MAT. Another review of case reviews, meta-analysis, and random clinical trials concluded that MAT with psychosocial services at least doubles the rate of positive outcomes when compared to treatment with placebo or psychosocial treatment without medication. And a study in Baltimore found that increased access to medication-assisted treatment for opioid use disorder, particularly expansion of buprenorphine treatment, may have significantly contributed to a reduction in heroin overdose deaths from 1995 to 2009. MAT is considered a standard of care for opioid use disorders, and it is crucial that providers in both primary and specialty care settings become trained to prescribe these treatments. Equally important, insurers and policymakers must promote policies that include these medications as part of a comprehensive approach to treating substance use disorders. But there is stigma around the use of medication-assisted treatment, and the bias has resulted in a dangerously low rate of uptake. We see stigma among providers and insurers. We see this stigma in drug courts that may not allow the use of all available medicines, and we even see stigma within some of the fellowship programs. There are many paths to recovery, and they should all be supported. Let me tell you a little bit about some of the federal actions that have been undertaken to drive change on this issue. In March, the U.S. Department of Health and Human Services announced a targeted initiative aimed at prescriber training and education, increasing the use of naloxone and expanding the use of MAT. The Substance Abuse and Mental Health Services Administration recently published a final rule that increases the number of patients a doctor can treat with buprenorphine from 100 to 275. In the first year, it is expected that this increase will allow another 40,000, little more than 40,000 individuals to receive treatment, with an increasing number of patients for each year after that, with a total of about 271,000 individuals being able to receive treatment within 5 years. This is also expected to have a significant impact in rural areas, which are currently served by smaller numbers of physicians certified to prescribe buprenorphine. In addition, our Health Services Resource Administration is devoting $200 million in funding to improve and expand substance use disorder services at community health centers with a focus on medication-assisted treatment. CDC has published guidelines for prescribing opioids for chronic pain earlier this year. Last July, the Centers for Medicare and Medicaid Services started a new demonstration program to allow states to test innovative approaches for substance use disorder services that also include MAT. The Department of Agriculture is devoting $1.4 million in grants to support rural areas as they address the opioid epidemic. And recently, the Department of Veterans Affairs is releasing a new policy requiring prescribers of controlled substances to check state prescription drug monitoring programs to ensure that a patient is not receiving multiple prescriptions that could threaten their health. The Mental Health Parity and Addiction Equity Act was passed in 2008. Chris talked a little bit about that. The goal of this parity law was to increase access to mental health and substance use disorder treatment services by requiring that insurance coverage for those services be provided in a way that was comparable to the coverage one would receive for medical and surgical care. A few things to understand about the law. Comparable does not mean you get the exact same services as one would get on the physical side. It means that insurance companies can't impose requirements for mental health and substance use disorder care that they don't also impose for medical and surgical care. For example, a company cannot require larger or more frequent copays or separate deductibles. A health plan also may not impose non-quantitative limitations. For instance, pre-authorization requirements must be comparable to what is required for medical or surgical care, and the processes for making decisions about coverage must be similar. The law does not require that insurance companies cover treatment services. Rather, it requires that if those services are covered, they be provided in ways that are comparable to medical surgical coverage. Some plans are required to include mental health and substance use disorder services as an essential health benefit under ACA, and when this is the case, ACA requires the benefit, and then parity kicks in to require comparability of coverage. Unfortunately, the implementation of the parity law has been inconsistent. And as a result, in March of this year, the President established a parity task force to identify the barriers to full implementation of the law, to promote best practices that can be used by federal and state agencies to ensure compliance, and to identify areas that could benefit from additional guidance. The President is committed to assuring the full realization of the parity law. A series of listening sessions, as Chris said, are taking place across the country to hear the perspectives and recommendations of consumers, providers, insurance companies, state insurance commissioners, and others. And this will culminate in a report that will be prepared for the President before October 31st. So that is just a little bit about what we are doing to address the problem. And here are some other ways that you can get more information about what we're doing. So that concludes my presentation, and I want to thank everyone again for inviting ONGCP to join you today.